Good morning, everybody. Thank you for joining the Peer Support Supervision training. My name is Christy Johnson. I am the Peer Support Administrator with the Behavioral Health Division. Today, I will be joined by two of the most wonderful people, Jean and Ike from Appalachian Consulting, who will be spearheading today's training. Appalachian Consulting is who we contract for peer support training, so I'm sure many of you guys recognize them from doing the peer support training. Today, our schedule is going to go for approximately 3.5 hours, ending roughly between 12 and 12:30. This meeting will be recorded. If that's something that you're not comfortable with, feel free to jump off and just know that we will be uploading this training to the behavioral health website, so it is available ongoing. For this training, you're not required to have your cameras on, and we do ask that you remain muted. We will be utilizing the chat box feature today to answer any questions that arise through the training. Feel free to ask anything, anytime, like something pops up in your mind, type away. We're going to be monitoring the chat box the whole time. Our learning objectives for today will be answering questions such as, what is the role of a supervisor? How can my team effectively use peers? Is supervising a peer support specialist different than somebody else on the team? This morning, we will be providing a manual for you to follow along with, and momentarily we will place that attachment in the chat box. We did put a link in there a little bit ago, but we're probably going to do one again just to make sure that everybody receives it. At the end of the training, we will also be dropping a survey link in the chat box. Once you complete that survey, you will receive a certificate of attendance within approximately 7 business days. With that said, when we post this training on the website for ongoing use, the same survey link will be added to the end of the video. That way, when individuals watch the video online at their discretion, they can also receive their certificate of attendance in a timely manner. Last but not least, we love collaboration, right? This is really about our community and professionals growing together. So please feel free to share your contact information or any site throughout the training with each other in the chat box. With that said, I will now introduce you to Jean and Ike and let them get started. And again, thank you for joining, everybody.
Now, Jean, did we ever figure out a way to get to know how many of different kind of staff we have here?
I am going to launch a poll where everybody can talk about what there's simply 2 questions on the poll. And this is just an opportunity for us to get a feel for who is on the training here. So I'm going to launch this poll. If everybody could answer those 2 questions, that would be great. Does everybody see the poll? Perfect, thank you.
Now, how long will this take to tally and get back some figures?
Just a few, maybe a minute or 2. 19 people have answered already. Almost everybody's answered. All right, so I don't know if I can post this 22. I'm going to go ahead and end the polling and share results. Can you guys see the results?
I need to do mine.
Oh, let's see. Relaunch.
I'm Vivian. I logged in.
Oh, that's okay. That's okay. Don't worry. Are the questions were behavioral health specialist? Behavioral health professional, peer support specialist, supervisor of peer specialist, administration management. What is your role? So 45% are behavioral health professionals, 45% peer specialists, 36% supervised peer specialist, 18% administration management, and 23% other. And then my agency currently hires peer support specialists, 55%, a little more than half, and my agency plans to hire peer support specialists at 40%. I'm going to stop sharing results.
All right, thanks, and thanks, Jean, for that. In order to get started, why do you hire peer specialists, or why would you, if your agency is already hiring peer specialists? Let's just get a sort of warmed up for this training. Why would you hire a peer specialist? Anybody, maybe put your comments into the chat box. Why should an agency hire peer specialists?
To help you with whatever programming you have. To assist people.
Good people.
Those shared experiences allow individuals to connect better with the participants of your program.
We're going to get into that power of connection a lot during the day. Okay,
Kyle says provide ongoing support, wraparound services. Stephanie says to add support and bridge resources.
Okay, now one of the things we're going to do today is we're going to have a series of PowerPoint slides. You do not necessarily need to follow your manual while you're doing the slides. You can take notes or whatever. And then whenever you get around to it, you want to download the manual. Most of what we will be saying and sharing with you will be in the manual that was put into the chat box. Any questions before we start?
My name is Crispin Baker. I'm not really sure. I'm not really too sure on what I'm, what the peer support specialist really even entails. A friend of mine that's doing it put me onto this, and he really didn't explain a whole lot about what the job is, but he said he thought I'd be perfect for it.
Crispin, did you sign up for the peer support training?
Yeah.
Okay, so we can go over that. What I'll do is I think I seen a friend request or an email from you. Let's connect after the training and talk more about it and make sure we can figure out how to get you into the training and stuff like that. Right now, we're going to be focusing on basically what it's like to have peer supports on your care team. But we would totally love to fill you in more on what the peer support specialist role is as well.
Okay. All right. Sorry.
Awesome. Thank you.
Now I've lost the slide, Jean. There we go. There we go. Thank you. The name of, you're going to end up hopefully in 3 hours knowing something about the role of the peer specialist and what they do and what we've learned about peer specialists. The name of this training is Peer Specialist Supervision in Behavioral Health System. Yet the major focus of the training is this is not a supervision training. It's a training of applying the principles of supervision to supervising peer specialists. So if you're a supervisor, we assume you've had some supervision training and didn't come to this training in order to be trained as a supervisor. We're going to talk about how do you take what you know as a supervisor and apply it to supervising a peer specialist. Now, the reason this training is in such demand is that clinical supervision of peer specialists is not based on the #1 principle of supervision. Now, let me tell you what that means. The concept of clinical supervision is rooted in the concept of mentorship or apprenticeship. It is a working alliance between a more experienced worker and a less experienced worker. Another way to talk about supervision is it's a means by which a junior member of a profession is brought along in order to become a full member of that profession. When viewed this way, clinical supervision has always been seen as peer supervision. Nurses supervise nurses, therapists supervise therapists, social workers supervise social workers, and so forth. The person being supervised is being supervised by a trained, the supervisee, the person being supervised, is being trained and molded by a seasonal professional who was a peer to carry out the duties of that profession to the best of their ability. Clinicians are not professional peer specialists in relation to the peer specialists. Peer specialists are not being supervised and trained and molded by a seasoned professional who is a peer to carry out the duties of that profession and the best of their ability. Now, what does all of that mean? Any issue that arises around clinical supervising of peer specialists was not created by the clinical supervisor, but was created by the absence of a peer-to-peer relationship. Now, why is the questions that this training is going to try to answer? Why has clinical supervision of peer specialists become a difficult supervisor relationship? Peer specialist supervision is in great demand as a training. Now, the other question is, how does a non-peer supervisor relationship impact the effectiveness of peer specialists, providers of peer support? The third question is, what have we learned about making the clinical supervision of peer specialists as effectively as possible? Now, we're going to also give you some tools at the very end that we're going to give you like a toolbox that you can use back at your agency to continue the discussion of what we present today, and maybe even bring some people in from your agency who were not able to go to this training. You can bring them in on that kind of discussion and with some of the tools that we'll be sharing with you. Any questions on what we hope to cover in the next 2.5 to 3 hours? Now, why has clinical supervision of peer specialists become a difficult supervisor relationship? Maybe a little history will help you understand this. The first Medicaid billable peer support training program was held in Georgia in October of 2001. Since that time, the program has spread to at least 37 states and the District of Columbia, plus some foreign nations. I'm always sort of amazed. If you think back 20 years ago and you went onto your computer and Googled peer specialist, nothing would come up. That term did not exist in the behavioral health field. Now, if you go in and Google peer specialists, you'll just get numerous hits. Now, also, we estimate, it's hard to know, but we estimate that there's somewhere around 20 to 25,000 certified peer specialists nationally whose agency can bill Medicaid. Now, what is the significance of peer specialists being able to bill Medicaid? Well, peer specialists don't bill Medicaid. What is the significance of an agency being able to bill Medicaid for peer specialist work? If you cannot bill for a staff member's work, you probably would not hire that staff as a provider of service. So getting the backing of Medicaid, which we did in Georgia. Now, we thought we were doing Georgia a favor when we set this whole thing up. But what we've learned is it began to expand so quickly. We were only into this a little bit, and our neighboring state, South Carolina, calls us up and said, we understand that Georgia has figured out a way for people who have a diagnosis of mental illness and of doing well in their recovery to work for an agency, and the agency can draw down Medicaid for their services. We said, yeah, we figured out a way to do that. They said, could you come to South Carolina and help us set up the same program? So we went to South Carolina and helped them set up that program. There was a very high official in Georgia who had left his work in Georgia and went to Hawaii because Hawaii had gotten into trouble with the federal government. And he said, could you come to Hawaii and help us set up a peer specialist program in Hawaii? I think it will help with what's going on. Well, that's a long plane ride. We talked about it, but anyway, we decided to go to Hawaii, help them set up their program. I don't know why we got the South Carolina program set up pretty quickly. It took us, I think, 5 trips to Hawaii to get that program set up. But we got the program set up in Hawaii. And then the next thing we knew, Texas calls us, then Michigan calls us, then Mississippi calls us. Well, they were really calling Washington, D.C., SAMHSA and other agencies in Washington, saying, we understand that there's a way to hire people with a diagnosis to work as mentors in the system. They said, well, yeah, Georgia started it. Georgia's the only one doing the training for that right now. You need to contact Georgia. So before we knew it, we were working with 25 agencies, 25 states to help them set up the program. Now you see the map which you have in your download. The gray states, the dark gray states are the ones that have Medicaid billable peer support services. Now the states that aren't shaded dark gray probably all have peer specialists. They just aren't in positions where the agencies have gone about certification and hire them in a way that they're used to pay down mental health, behavioral health with Medicaid. So there are probably peer specialists all over the country, but those shaded states are the ones that have approved Medicaid billable programs. Now, initially, peer specialists were hired in Georgia, Medicaid approved, to work in 3 positions. You could either be on an ACT team, assertive community treatment team. You could be on just a community treatment team, or you could be in a peer-run day program. Those were the only 3 places that people could work and get Medicaid billable services. Now, we all know that peers work in a lot more places than that. They work with homeless, they work with youth, they work with crisis centers, they work in just about any place the behavioral health system peer specialists can work. Now, there are Medicaid-approved certification programs for addiction, for youth, for forensic, and for family peer specialists. Since this map was created, Alabama has been added to the list. And so you can shade out Alabama when you get your list. Now, what's the significance of this? And how does this relate to what we're talking about today? Well, what happened was the Center for Medicaid Services, CMS, which is Medicaid, Medicare, sort of said this program is going so fast that we need to step in and do something to sort of begin to give it some kind of parameters of control. So Medicaid billable peer support services was growing so quickly that in 2007, by 2007, we were working with 10 states to set up their program. In August the 15th of 2007, the Center for Medicaid and Medicare Services, CMS, sent out a letter proclaiming peer support services an evidence-based mental health model of care. And they listed 3 guidelines that a program had to follow if it wanted to be certified by Medicaid. There had to be supervision, and we'll come back to that in just a minute. There had to be what they call care coordination. That meant that peer specialists had to work in a setting where all the programs were being provided. They could not just go out and hang out their shingle and start providing peer support and bill Medicaid. They had to be a part of the agency bills Medicaid, not the peer specialists. So they had to be a part of an agency that was providing a coordinated care system. And then they had to be a training and testing and certification program. Now, the significance of this for what we're talking about today was they said that supervision guidelines stated that supervision of peer specialists must be provided by a competent mental health professional as defined by the states. Now, in most states, a competent mental health professional must have the advanced degree. Now, since people need only a high school or a GED to go to the training, most certified peer specialists did not meet the qualifications to supervise. Now, what happened was someone had to supervise peer specialists. Peer specialists did not have enough education to qualify for supervisors. So they began to be supervised by non-peer specialists. Now, there is a statement from International Association for Peer Specialists and SAMHSA that sort of explains how we got to where we are today. So many states funded peer support worker positions through Medicaid reimbursement, which required supervision by a licensed or qualified mental health professional as defined by each state. Now, while this led to substantial growth in the peer support specialist workforce, it also resulted in peer support worker supervisors with no direct knowledge of peer support. Now, what does that mean? That means as peer specialists began to move into the workforce, they began to be supervised by people who were not peer specialists and did not necessarily understand what peer specialists did best, did not understand peer support. What do you think happens? What's the danger of it for the supervisor in supervising someone that is not in the same profession that they are in? Anybody? What could happen if if a supervisor is supervising someone who is from a different discipline or profession than they are in? Put it in the chat box. Think about it.
We have
No understanding of their role.
I like misunderstanding the craft, no understanding of the role, no growth, no guidance, conflict of interest.
Yeah. So traditionally, peer specialists have been used to supervising other mental health clinicians, and they tend to supervise peer specialists from a clinical perspective.
Yes,
this is where we're going to spend a lot of our time today, sort of trying to get our minds around, first of all, what is the perspective that a peer specialist brings to an agency that's different from a clinical perspective? And how does this affect the supervisory relationship? Because there are a few states that are trying to figure out a supervisory path for peer specialists so that peer specialists can meet the credentials of the state to supervise other peer specialists. But that is not happening in many states. So we're probably going to have clinical supervisors supervising peer specialists for the next few years at least. And so we need to understand the implications of that. So with that, I am going to turn it over to Jean to talk about the first. Are there any other comments about sort of what problems this creates when you're being supervised from someone who does not understand the gifts and abilities you bring to your role? Any other comments?
Yes. Will this history that you just gave be on paper in one of the slides or the packet that you're offering?
Yes, you receive in the chat room the material that you can download that gives you the information behind this PowerPoint.
Okay. All right.
Did you see that document in the chat?
I saw the document. Yeah, I downloaded the document. So my question is, it gave a lot of particular information about the step-by-step process in which this all came into fruition. And so I wanted to be able to get to that.
Yeah, that'll be explained
That's in there
when you have time to read the material.
All right, thank you.
Absolutely.
I would like to just jump in real quick and ask, Crispin, do you have a better understanding now on basically how peer support is using everything that you have been through to just help others and just how awesome it is? I just want to make sure that you kind of got a good grasp on it.
Yeah, I'm kind of figuring out. I don't see where the stuff to download is on the chat.
We can put the link back in there if that would help you guys. We can just send it
Okay.
again. Awesome. Thank you.
Do you not see that in the chat at all?
You may have to scroll up.
I'll drop it in again.
Okay.
There, I dropped it in again.
Okay. Yep.
Perfect.
It's the one that says Karen Clayton with Candor Professional Service, www.candorprofessional.
So try scrolling all the way back down to the most recent, and you should see a link that says ND Supervisor Training from Jean. It'll have a little Word doc symbol on it.
And it's in the chat box?
Correct.
Yeah.
Yeah, I'm not seeing it.
Scroll down to the bottom of the chat.
Yeah, I'm looking at the last chat I see is from David Bryce to everyone. I still don't see it.
Are you on your phone?
Yeah.
That may be the challenge, is that you can't download it to your phone.
Oh, okay.
So it may not show up because of that.
Okay.
So what I'll do, you guys, is I'll just send you an email with the attachment on it.
Okay, thank you.
Yes, of course.
So on the next section, the question we're going to address is, how does this non-peer supervisory relationship impact the effectiveness of peer specialists, providers of peer support? Now, a lot of the research around, as Ike mentioned, that peer support has been around for decades before it became a billable service. Is that, everything from a 12-step group is a peer support group. Everything from Weight Watchers is a peer support group. There are lots of different types of peer support. It's kind of new bringing it into the behavioral health system. And in your manual, you'll see we have some articles on what research has shown the benefits of peer support. Things like that improves quality of life, it improves engagement and satisfaction with services and supports, improves whole health, including chronic conditions like diabetes, decreases hospitalization and inpatient days, and reduces the overall cost of services. Peer support empowers people to make the best decisions for them and to strive towards their goals in their communities. Peers are an essential component of recovery-focused systems and are key across settings and stages of recovery. Bringing that power of lived experience. An example I often give is that, how many of you are parents? How many of you have got great information on raising your children from doctors, any other professional, correct? They've provided really good information and support. At the same time, how many of you have gotten really great information from other parents? That is the difference with, so what else might be a benefit of peer specialists in the workforce? I was checking the chat, or you can talk.
Rapport.
That's a really great point, Carl, is that one of the things that peer specialists do bring is that when I'm talking to another person with lived experience, there are so many things I don't have to explain. You know, I used to introduce myself as a peer, and I would say I've been hospitalized, medicated, and lied to my psychiatrist. And clinicians would be like, well, why would you lie to your psychiatrist? And I'd be like, because they have the power to think I'm crazy.
Yeah.
So there are so many things like that that you just don't understand.
Right.
In the chat, it says they've been through addiction and can voice their past openly. And I think that's huge too, is that it is also very empowering that things I may have guilt and shame about in my past, a peer doesn't hold that against me.
I think because we're trained, you know, some of us don't know how to voice our experiences, but the training teaches us.
Yep, absolutely, absolutely, absolutely. As I mentioned, is that, you know, not very many years ago, if you Googled peer support, there you wouldn't find a whole lot of information on it. There are lots of research ongoing about that impact of peer support, showing that it lowers the overall cost of mental health services by reducing rehospitalization rate and the days spent in inpatient services. And quite frankly, that is why North Dakota has brought in peer support, is that and free through recovery is that they found they were spending too much money on other services. You know, from the mental health side, people were being hospitalized. From the substance abuse side, people were being incarcerated, and that costs a lot more than providing services in the community. It increases the use of outpatient services, improves the person's quality of life, improves engagement with services, and increases the whole health and self-management. I think that's very important, is that I think a peer also brings the whole question of a person's whole life, not just when was the last time you used, you know, but the questions of the whole person's whole life. So let me go to the next slide. Let's talk about why we're doing this. Agencies often hire peer specialists without thinking through why they are being hired, what special gifts and abilities they bring to the agency, and where they can most effectively be used within the agency as providers of services. In Michigan, we started our peer support specialist program about 12 years ago. And I think that a lot of agencies said, oh, look, we can draw down Medicaid money for this service, but we don't know why we're doing it. Or states were told that they have to hire peer specialists and not thinking through why. Also not thinking about what is the unique service that a peer brings, as well as where can they best be placed in the agency. There are certainly some areas in the agency that wouldn't benefit best from a peer, and there are other areas where they would excel. Sensitivity, understanding, non-judgmental acceptance, and connection. I mentioned this briefly, but because of their lived experience, peer specialists bring a perspective and a set of gifts and abilities to the agency that has not traditionally been present in most agency. That it's not just the information, lived experience, and the wisdom that the peer specialist brings to the person receiving services, but is also how that experience and wisdom can bring that information to the agency. You know, the peer specialist has sat in the waiting room. The peer specialist can share that experience with the agency about what is it like to sit in the waiting room. The next one, peer specialists seem to thrive in agencies that understand and are committed to recovery. And sometimes that is about educating the agency about what is recovery. You know, I like to say is that, you know, recovery seems like this brand new invention. You know, in the 60s, they kind of thought everybody needed to be institutionalized. In the 70s, they said, well, some people recover. And we're at a place now where it really is possible for everyone to recover. Everyone to get a life of meaning and purpose. So having an agency that understands and is committed to that concept that everybody can recover. And unlocking the potential. The supervisor is key to incorporating the peer specialist workforce into the provider workplace. That is the key relationship. That is the key dynamic of how the peer will interact with the agency. It is key to how the peer will interact with those in services. It really is that supervisor relationship. You know, as most of us know, is that if you have a supervisor that really understands your job, it helps you to do your job better. And that's what we're going to talk about today. I have you guys on top of my thing here. On the next page, if you're following along in the manual, we're talking about the why, what, and where. While the peer support service program has largely been effective, being hired by agencies that have not thought through that why they're hiring peer specialists, what the special gifts and abilities they bring to the agency, and where they can be most effectively be used within the agency as providers of services, the peer specialists supervised by non-clinicians with no direct knowledge of peer support values have created some major problems for the peer specialist, the supervisor, and the agency. So what are 2 or 3 problems that this could cause for the staff, and especially the supervisors, if people don't understand that why, what, and where of peer support? What might be some of those challenges, especially for supervisors?
Yeah, somebody say something. Oh, sorry. Sorry, I didn't know I was unmuted.
It could have been way worse.
No. There were a number of you when we did the poll in the beginning that are already supervising and working in agencies with peers. What were some of the challenges for you when you were first told that, because most of the time supervisors just get individuals added to their supervision caseload, right? And are not necessarily told what the person is supposed to do. How has that been a challenge?
I guess I don't know how to use them effectively, you know, like, I guess to try to build a caseload, and then, I guess I would try to go by my application and see whose personality, or not personality, but the one I guess it just takes working with them and having to get to know them, and then placing them in the proper place. I would think.
Yeah, absolutely. It's like, you know, if I gave you these pliers and didn't tell you how to use them. Not that I haven't used pliers as a hammer before, but it's not about effectively using them.
I think maybe I'm in the wrong class, because I'm not even a peer support specialist yet. So did I sign on to the wrong, because I'm wanting to be a peer support specialist, and this is a class for a peer support specialist supervisor, correct?
Crispin, you can still join. I think you could learn a whole lot about being a peer support specialist on this call. And
Okay.
another thing that you could consider is when you do sign up to be a certified peer support specialist, this training is one of the requirements eventually to be a peer support specialist level 2. So I think since you're on, you might as well just learn if you want.
Yeah. Oh yeah. Yeah. I'll stick around. Definitely.
Glad to have you, man.
So do the ones that are certified go to level 2 then?
We can talk about certification at the end. However, if you're certified and you'd like to be certified for a peer support specialist level 2, the requirements for that are this training and then proof of over 1,500 hours of direct peer support hours.
Cool, thank you.
Of course.
Did you have a question, Gabe?
I just wanted to add that one of the challenges that I've had is that I understand the value of peer support specialist role, but my supervisors, the people that hired them, the people that put them under my supervision, don't understand or value their lived experience as expertise. And so trying to find out where they fit within an agency and what they can bring to the table that isn't necessarily clinical or like in that realm of like case management-esque stuff has been really difficult for them to understand the value of like just having someone who can say like, I understand what you're going through and I can sit with you and be present for you with you for this. Can like they don't see the benefit of that.
Yeah, and not an unusual situation, especially with a new workforce. You know, one of the first professional associations was the Psychologists Association. Because when the psychologists came along, the psychiatrists were like, oh, who are these touchy-feely folks? And, you know, I don't know how we're going to utilize those folks. So it is not an unusual process to be in. And it's kind of interesting that, you know, I mean, we're talking about how to supervise peers and making sure that the peer supervisor understands. But you have a great point, is that as a peer supervisor, you also need your supervisor and your agency to understand. Absolutely. Anybody else? How else could this cause some difficulty in utilizing peers if people don't understand what? I have honest to God heard people say, I don't even know why we're hiring peers. Why would they say that?
They don't understand the value in it. They're not aware, they don't have enough information about how useful it could be to hire peer support specialists and even how to use them effectively.
Yes, I like the two people that said that in the chat. Jean, say that not enough education, not enough professionalism. I like those two a lot, just to be touching base on a few things since I've been quiet this whole time.
Yeah, absolutely. To what you're saying is I think that is one of the concerns, is that they don't feel like they have enough education. I think oftentimes there's the fear of the whole liability question, you know, and I think some of it comes from, you know, the whole stigma of, well, I got into this profession to help those people. Now I'm working side by side with those people. And it's not about, you know, being evil or anything like that. It's about understanding what are those gifts the person is bringing. In the manual there, it says, since the peer specialist workforce is a new workforce, the gifts and abilities they bring to the workplace are not always understood and appreciated. It is very important that the peer specialist supervisor understand, support, and promote the values and principles of peer support. One of the major responsibilities of the peer supervisor will be to help maintain the integrity of the peer support services and the role the peer specialist within the agency. How this is done will be discussed later in the training. And that's exactly what, you know, Gabe was referring to, is that, you know, as a supervisor, You are not just providing that guidance to the person you're supervising, but you're also going to be a part of that change agent with the agency and educating the agency about what peer support specialists are and what they are not. Oftentimes I know of supervisors that have had to tell other clinicians in the agency, for example, no, the peer specialists that work for me cannot just drive your folks around to appointments. Their job is more than that, you know, and that is going to also be part of the role of the supervisor. If agencies do not understand the philosophy and values of peer support and have not carefully thought through how and where peer specialists can most effectively be engaged, this can result in disengagement of the peer specialists in two forms of engagement that do not allow the gifts and abilities of the peer specialist to flourish. The peer specialists either leave or will be co-opted and marginalized. Next, whoops, next slide. First of all, they are often co-opted. The definition there is being taken in or assimilated by a group in such a way that they're not seen as different. Sometimes agencies want the peer specialist to be a mini clinician. That is not the role of a peer. Sometimes, but it is because that clinician has been working with individuals with those clinical glasses on. That's the way they see the world. Not understanding that the role of a peer is to see things from a different angle. Oftentimes they want they think the role of the peer specialist is just to continue what we've been doing and not about enhancing what we've been doing. Second of all, they can often be marginalized. The definition of marginalized is to be relegated to an unimportant or powerless position within a group. Oftentimes, if you do not know how to utilize this tool, you will set it aside and not use it. You will have folks just driving people around. You will have folks just filing, I don't know what to do with you, so why don't you alphabetize these files? You know, and again, it's about not having thought through where and how the peer specialists fit in. The role of the peer specialist supervisor is to ensure the peer specialist is positioned and encouraged to perform their unique role. Do you see that co-opted or marginalized as a challenge at your agency? Anybody want to share any examples? Or let's talk about, are there any fears you have about peers being co-opted or marginalized? You can put it in the chat. You can put it in the chat directly to me if you don't want to be specific about anything.
I don't really feel like, so when I first started, I was like, okay, what am I doing here? I've never done this before professionally, and they didn't know. So it was, well, I'm gonna have you shadow the front desk for a day. So then after shadowing front desk for the day, the second day it was like, well, just do what you did yesterday, but try to talk to some people, just talk to them, you know, figure out for yourself what you need to be doing here. And so I was a little bit lost. I'm starting to work into like how it works now, but it's taken me 3 months. So, yep. And then some people are like, well, shouldn't you be doing this? Shouldn't you be doing that? I don't know. Nobody's guiding me. So
that is a great example about how that partnership needs to happen, how that collaboration, we're sitting down, and we're going to go into that this afternoon or later on this morning about, you know, how that partnership with the supervisor and the peer needs to talk about where can I be utilized? Your experience of, well, we don't know what to do with you, so just shadow the front desk person. That is a very, very common. And and oftentimes in the peer specialist trainings, I talk to folks about, you're going to go into the workforce and feel like you don't know what you're doing. Well, the truth is that the agency doesn't know how to utilize you either. So if you look at this as a co-education, mission where you are explaining to the supervisor and the supervisor is talking to you about, how can we figure this out together? So not uncommon.
And I want to be fair, that does exist. That has existed all along as well.
Yeah.
So I need to be fair there. I work for someone great.
Oh, yeah, absolutely. Absolutely. It's not that, and really to stress that it's not that, anybody's trying to be evil or anything like that, is that it's just that if you don't have awareness of the possibility of co-opting and marginalization, then that's where people will end up. And if you don't keep that in mind, you will lose good peer specialists because they don't know what they're supposed to do. It's hard to work in a job when I don't know what I'm supposed to do and I don't feel like I'm being effective. And as supervisors, that's what you want out of your employees, is you want them to be connecting with the people they serve. You want them being effective. You want them being a part of the team. Anybody else?
Yeah, I just wanted to add, it's Gabe again, that I work with youth and sometimes it's their first job. And I think there is a lot of pressure on them to be perfect, with time management, with all of these life skills that they don't really have time for. And the second they mess up, it's really hard for, I have to advocate a lot to make sure that they aren't fired immediately for mistakes that they just need help working through. So this idea that they're supposed to be the perfect employee or they're not a good representation of the program is really challenging for me.
Yeah, and I'm sure that Gabe, when you were assigned these peer specialists to supervise, I'm sure that the agency gave you extra time for the supervision, right? Because that's a challenge too, because supervisors all have jobs to do too, and now you've added a whole nother workforce on their plate, that it makes it very tough. And again, if you're not aware of some of these dangers, it can be really easy to slide into that. Anybody else? Any thoughts around the co-opt marginalization challenges? All righty. We can go into the next. Do you want to start into the next section, Ike?
Yeah. I just want to say that this co-opting and marginalization is not because people are mean or vindictive or trying to get at people. I have never met a mental health professional that did not have more on their plate than they had time to deal with. And therefore, one of the things that tends to happen when a new staff member is brought on, and there's a tendency to see this new staff member as not as educated as you are, but certainly capable of doing some of the things that you don't have time to do. And so I think one of the things that tends to happen is a new person comes on the scene. They are not clear what they should be doing. So there are times when they're sort of sitting around doing nothing because they don't know what they're supposed to be doing. And if you see someone sitting around that has nothing to do, it's kind of natural to say, I have so much to do that I can't get it done. Would you help me get some of it done? And so you really sort of say, it's very easy for peer specialists to slip into that role of being an assistant to the clinicians. And we want to spend, where we're going to move now is the sort of the third question that we want to look at this morning. And that's where we're going to spend most of our time, is how do you take where we have gotten to right now with supervision and make it as effective as possible. And because it's a pretty lengthy and detailed session, why don't we've been going about an hour or a little more. Why don't we take a 10 or 15 minute, take a 15-minute break, sort of get some coffee, go to the bathroom, find your manual, whatever you need to do. And then we're going to come back and try to really get into what have we learned about making clinical supervision of peer specialists as effective as possible. So let's come back then at, what would that be, 10:15?
Oh, 11:15, because they're Central Time. So, although some of them are Mountain Time. I don't know if we got anybody out in Dickinson or not.
Well, let's just say 15 minutes.
Quarter after sounds perfect.
And we're ready to get into this, really the question of the day.
Hi, Ike. It's really good to see you. It's Tila. Really
How you
happy to see
doing?
you.
Good to see you.
How have you been through the COVID?
We've
Good.
gotten through. I've had my vaccinations, and we've gotten through it pretty well. We've had some friends that didn't get through it, but I mean that died from it. But we've been doing pretty well.
Yeah, that's how it was with the community here on the reservation too. It was kind of going back and forth with the not being able to communicate or be in the recovery realm of people coming in and showing up, and then overdoses. I mean, I seen some statistics on overdoses where you guys are at too. You guys, it was tough. It was a tough year. But you remember us guys visiting so much as my mom, the warden. Remember, she's the director of public health here.
Yes.
So she was the frontliner for the whole reservation that deals with COVID and the vaccinations. So that was a little bit of heart-wrenching on the family because that's what she was built for. She said, you know what I mean? Her education and stuff wise, this is what I'm made for and built for, Tila. And it was, no, Mom, you're my mom.
Oh, she rocks.
Oh my gosh. She's so professional and she's so to the book. She's just a warden. So she came through it really good. She did she was one of the first couple people that got vaccinated here on the MHA Nation. And we had talked about it a month before and we weren't sure we were gonna do it, but she took on the role of saving people's lives, like how, us guys do in our jobs, and people in recovery and stuff, and doing what we have to do. And we did ceremony. We had a lot of stuff like that before she did the vaccination and stuff because we were scared because she's an elder. She's an old Rick Raw lady, but it was no face to her. Holy smokes. So it was good. It was good. So
It's hard to tell if people are back or not.
Back?
I think we're good to get going again.
All right, that sounds good. We're going to move into answering the question, what have we learned about making clinical supervision of peer specialists as effective as possible? In a way, the Medicaid guidelines for supervision has put supervisors of peer specialists in a very difficult situation. It's not their fault. It's just something that's happened in the system. Can you imagine if you say you are a therapist and you've been asked to supervise a nurse and make her the best nurse she could possibly be? Let's say you've never met a nurse before. You don't really know what nurses do. And yet your role is to make her the best nurse she could possibly be. That's a difficult job. And so I think the first thing we've learned is that the agency, the treatment team, and the supervisor need to understand the philosophy and values of peer support. If I am going to help a nurse become a nurse, I need to know something about nursing, not just this nurse that I'm nursing, that I'm supervising, but I need to know something about nursing. So let's take a minute and reflect a little bit on peer support. Now, Jean talked a little bit about peer support earlier on, but peer support is basically the act of people with a common experience getting together to support each other. It can be done anytime, anywhere, two or more peers are gathered. Peer support can take place over a cup of coffee. It can take place at the water fountain. It can take place anywhere. Now, it's a human dynamic. I can imagine 1,000 years ago, a cave woman saying to the cave woman in the next cave, "What do you do when your husband does blank?" That's peer support. When you encounter this situation, and you've probably encountered, how have you learned to handle it? We've all experienced, you've probably experienced peer support personally. You've probably experienced peer support professionally. You've probably had times in your life, if you were raising a teenager and you were having some difficulties with this teenager, and you have a friend who is raising 3 teenagers and seems to be doing a pretty good job at it, you're going to go to that friend and say, "Can you help me raise my teenager? Can I talk with you about some issues that's peer support." Now, in basic peer support, the neighbor could say, "No, I don't have time to talk with you about that. I don't care to talk with you about that." Or your neighbor could come to you and say, "I understand you're having some difficulties with your teenager. I've raised 3 teenagers and I've done a pretty good job at it. Let me tell you some things that might be helpful." You could say to that peer specialist, to that neighbor, I don't want you to help me. So when peer support becomes a service, it changes a little bit, and we'll get into that a little bit later. But what happens when peer support is brought into the mental health system? You have to understand to some extent, I think, what living with and being diagnosed with a mental illness does to people. There is nothing a person can lose that can't be lost with the onset of what we call a mental illness. It can just devastate a person's life. They can lose their family, they can lose friends, they can lose jobs, they can lose their education, they can lose their housing. One person, they can lose their sense of dignity, they can lose their self-respect. People's hopes and dreams are often shattered. They are often told that they're going to have to give up their hopes and dreams, that their life as they once knew it is over. It's just, there was a lady who said in one of my trainings, not only did I have to give up my hopes and dreams, I even lost my ability to dream. So we're talking about peer support at a little bit deeper level than what would just be professional or personal peer support in terms of with your teenagers and so forth, because there's no illness, I think, that can cause so much questioning of who one is on the other side of that diagnosis. And then to meet someone who has experienced what you are experiencing and seems to have come through it a stronger person is a very, very empowering experience. And so that's one of the roles of a peer specialist, is to share what they have learned from their lived experience about dealing with whatever another person is dealing with at that time. Now, there are two values of peer support that impact the work of a peer specialist. The first value is what I call mutuality, sharing equal status and giving and receiving support from each other. As I mentioned earlier, two people come together. They're both, one's got some experience in an area, the other is struggling in that area. So the one that's struggling in that area shares what's going on with the other person shares what they learned. But in that situation of pure peer support, the second person also sometimes says, I have got some things that I'm going through, and I'd like to know how you've dealt with them. Well, that's a little bit different when peer support becomes a service. If you think of mutuality as this way, both people learning from each other, both figure out the rules of the relationship, how they're going to relate, and the power structures that are always on the table to discuss. Now, when a peer support becomes a service, it changes a little bit, because peer specialists do not use the peers for their own support. So instead of in pure peer support, it's a two-way street. I will share with you and learn from you. You will share with me and learn from me. But when peer support becomes a service, it becomes a little bit more of a one-way street. Someone described it this way, that a peer specialist is a friend. Now, I would imagine any clinical professional would never think of a client as their friend. They are a client that they are working with and providing a service to. But the peer specialist role shifts. One of the values of peer specialists is this mutuality. It says peer specialists are friends, but a friend with a purpose. I'm not just your friend. I'm a friend who is here to support you in your recovery. So one of the roles of the peer specialist supervisor is to help the peer specialist maintain appropriate boundaries within the clinical setting of the agency, so that oftentimes agencies will have guidelines. You don't socialize with the people you're providing service to. You don't have dual relationships. So there's some things that begin to affect that relationship of mutuality, which is not quite the same as if it's just pure peer support. Any questions about this mutuality? and how a peer specialist relationship with a peer is different from a clinician's relationship with a client. It's very.
I don't really have a question, but it sounds a lot like a lot of the things that I do already within Narcotics Anonymous. I sponsor, a few people, and I'm kind of like a life coach to the sponsees that take my advice. But at the same time, I don't. I have to maintain kind of a role, that doesn't allow me to get too friendly with them to where, they still, I mean, there's like a barrier there, that in order to keep the, like the mentor level mentality, you know what I'm saying? I get it.
Yeah, one of the things about being a peer specialist is you have a working relationship with your peers. I mean, you are a peer specialist that's providing a service to your peers. This usually means you don't socialize with them after working hours. That's a whole different relationship, because then things come up that can affect the professional relationship that you have with them during the day. I tell this story. A man was walking along, and someone had a chat up there. I didn't get to read it all. You see it, Gene?
Yeah, I was trying to unmute. A man was walking along and fell in a hole. He called out for help. A doctor walked by and threw in a prescription. A psychologist walked by and threw in a treatment plan. A minister walked by and threw in a prayer. None of them helped him out of the hole. Then his best friend walked by. The man called out for help again. His friend jumped down in the hole. The man said, "Why did you come down here? Now we're both stuck." His friend said, "I fell in the hole before. I know the way out."
Okay, a story that begins to get at some of the difference. Now, the second value of peer support is that it is voluntary. And I think this is one of the things that agencies have a hard time understanding. As I mentioned earlier, in peer support, if your neighbor comes over and says, "I understand you're having some difficulty with some of your teenagers, can I help you out?" And you may say, "No, I don't want any help." You volunteer to have a relationship with someone else in peer support. Now, what this means in an agency, each party chooses to be part of the relationship. Peer support specialists should not be assigned a caseload like everyone else is assigned a caseload. I'll give you an example. I was working with a state. They had health homes where it was a comprehensive physical, mental, spiritual services being provided to support the peers. They had a nurse on the team, and they had a community support person on the team. The funding agency came in and said, "You have to put a peer specialist on this team." Now, before the peer specialist, I'm just going to say, let's just say there were 45 people, or let's say there were 60 people on this that they were providing services to. The nurse provided services to 30 of them, and the community case worker provided services to 30 of them. When the peer specialist came in, they just divided them 20, 20, 20. Each person took 20. That's not the way a peer specialist gets a caseload. The way a peer specialist should get a caseload is when people come in for services and are in intake, during the intake and admissions process, peer support is explained to them, and the role of a peer specialist is explained to them. And they are asked, would you like a peer specialist as part of your treatment plan? If they don't want a peer specialist as part of their treatment plan, they don't get a peer specialist. If they want a peer specialist as part of the treatment plan, they get a peer specialist. That means that they get this volunteer caseload to work with. And the peer specialist is then given time to work with this volunteer caseload so that people understand peer support a little bit. They understand what a peer specialist is, a person who has experienced some of what they're going through. Would you like to have a person like this on your team, on your treatment plan? They say yes. That's the ideal way to bring the concept or value of being a volunteer into the workplace. Any questions on that value and how it affects the agency? First value is mutuality. Second value is it's always volunteer. Now, one of the roles of the peer specialist supervisor is to help the peer specialist maintain the volunteer nature of this relationship, which means that oftentimes the supervisor has to be advocating for the peer specialist and making sure that the people the peer specialist is working with are people who understand peer support and have requested peer support as part of their treatment plan. Any questions? Now, a lot of times we do training with agencies who are just getting involved in this. I see where I think 45% of the agencies represented today are thinking about hiring peer specialists, haven't hired them yet. That's great to get in on this kind of training before you ever do it. And we're going to be giving you some tools down the road that you can use that are going to help you as you initially start hiring peer specialists and as you start providing supervisors for peer specialists. But what is a mental health peer specialist? Now, first of all, they're addiction peer specialists, the corrections peer specialists, their youth peer specialists, their family peer specialists, but we're just going to focus on the mental health peer specialists. Now, a peer specialist has the diagnosis of mental illness and has been able to control the symptoms of the illness through medication or coping skills and lifestyle so that the symptoms of the illness do not prevent them from functioning effectively in society. Each state has a little bit different criteria. They set their own criteria as to where a person needs to be in their own recovery before they can go to the peer specialist training program. Now, they have to have at least a high school diploma or GED in most states that we've worked in. And they have to have completed a state or Medicaid approved training and certification process. That's the basic generic understanding of a peer specialist. Now, you'll get a little bit more into this as we get into the rest of this, the morning. Now, the next question, what skill set do peer specialists bring to the table? Because of their lived experience, their major skill set is the ability to listen for what the peer is experiencing that makes them feel so alone, not understood, and unable to see that they can make any changes in their life and make their life any different than it currently is. So we come down very hard on the peer specialist training on the concept of listening and getting inside of what the peer specialist is experiencing. I mean, the peer is experiencing. Now, they can use their lived experience. It allows, we've talked about this a little bit. A peer specialist, because of their lived experience, usually is able to connect with a peer quicker and in a different way than most clinical staff because of this common experience. They can make this connection. Now, this ability to connect around a common experience creates a peer-to-peer relationship that is different than most clinicians have with their client. We talked about that a little bit. They have a peer-to-peer. We have similar experiences, been on a similar kind of journey. And so you have this peer-to-peer relationship. Now, this peer-to-peer relationship is based on non-judgmental understanding that validates what the peer is experiencing and creates a relationship of trust. Because of the way the peer specialist has been trained to relate to people and validate what they are experiencing, it's hard to be judgmental of a peer if you're a peer specialist. It's hard to be judgmental of a person who is doing something you probably have already done yourself. You've had similar experiences. And so you have this relationship of trust based on a sense of, I understand what you have been going through or are going through because I have been through something very similar to that. Now, this relationship of trust opens the door to sharing aspects of their life that they may not usually share with clinicians. Oftentimes, peer specialists are going to get information from a peer before the peer was, information that the peer will not necessarily share with a clinician. Now, this puts the peer specialist in a little bit of a tricky spot with confidentiality. But one of the things the peer specialist needs to make sure the peer understands is what confidentiality really is, and that there may be things that come up that they have to share with the team. And when you share something with the treatment team, you're not breaking confidentiality. The team needs to know that information. So deciding what to share with the team and what not necessarily is important to share with the team is something that peer specialists oftentimes struggle with. But you're going to get information because they trust you, but you cannot say to a peer, I won't tell anybody that. You have to make the judgment of whether this is something that you have to share with the team, and the peer specialist needs to share with the peer. There may be things that come up in our conversation that I'm going to have to share with the team. Now, also this relationship of trust opens the peer to receiving information from the peer specialist regarding recovery, coping skills, treatment process, agency services, community resources, all of those things that the peer specialist has made a part of their own recovery journey. The peer specialist says, if those things have helped you, then I'm going to be open to listening to you, and I'm going to be sort of willing to receive from you because I trust you. Now, one of the roles of the supervisor in supervisory meetings is to have conversations on a fairly regular basis with the peer specialist around what troubles are you having with your connections? Are you able to, what are there peers you're having difficulty connecting with? Are there peers you're having difficulty connecting them to recovery? Are there peers you're having difficulty getting them to trust you? It's very helpful. The supervisor who is not a peer specialist and will not necessarily understand how a peer specialist can use their lived experience to make these connections. That's why one of the things, if you're supervising a peer specialist, or at least more than one peer specialist, it's very helpful to do some group supervision so that the peer specialist can get support from other peer specialists under the role of their supervisor. When the supervisor brings the two or more peer specialists that they may be supervising in for group supervision, then some of that cross-sharing can take place where one peer specialist can say to another peer specialist, well, this is something I have found helpful, and the supervisor can help that process take place. Any questions about what they bring to the table that's a little bit different than what the traditional clinician brings to the table? This ability to connect, to create a relationship that's peer-to-peer, a relationship of trust, and a relationship in which a different kind of sharing and receiving goes on.
One of the comments in the chat is that the trust I have is often looked down on by the staff, and just kind of that struggle of how come you can get the person to share things with me that I can't, and how that dynamic sometimes comes up.
And this is where peer specialists have to just use their own judgment. But you have to have cleared with the peer, there may be things that come up that I have to share, because I am part of a team that's working to provide you the best of services that we can. And I think it's very important that the team know this information. But there may be things that the peer specialist comes up, that the peer specialist shares with you that has really nothing to do with their treatment. It's just information that you don't necessarily need running off to the team to share. Now, any other questions?
I think that goes along with the co-opted or that mutuality as well. And it's more like a burnout or a compassion burnout, I think is where that comes from. Because like I have hopes in what I'm doing will help the individual, and these people are like, no, you trust them too much. Well,
I think one of the things to help remind folks in that situation is that, my job as a peer is to help you to do your job better. Maybe better is not the right word, but is to help you to make those connections, to help us as an agency to make those connections. And it may be my job to trust them a little bit more, and it may be your job to trust them a little bit less, but that's where we find the balance.
Okay, let's move into the next. What benefits does a peer specialist bring to an agency? The following are some of the benefits. Now, peer specialists understand what the peer is experiencing and can ask questions that help the peer have hope and see possibility in making some changes. Because of a common experience, you sort of know what the person is going through. You can recall a time in your own life when you went through something very similar to that. And you can ask questions and make comments that sort of let the peer see that there's some possibility here, or that you made some changes and this is how you were able to make the changes, and maybe they can make some similar changes. Now, peer specialists help peers understand what services are available and how, when, and why they can best engage with them. This does not mean that the role of a peer specialist is to get the peer to be compliant with the treatment that the treatment team has prescribed. It means that the role of a peer specialist is to help the peer understand the treatment team and make recommendations as to how they would want their treatment plan changed, and work with the team to adjust the plan so that it really meets the needs of the peer. Probably one of the greatest benefits they bring to an agency is to help the peer understand and engage in the recovery process. We do a lot of work in the training programs on what we call the recovery journey, and how you can ask questions to help people begin to see some possibility and get engaged in recovery, working with them on what's helpful, what's not helpful.
One of the
peer specialists play or benefit that they bring to an agency is that peer specialists connect with peers that clinical staff may be having a difficult time connecting with. I've seen that happen a lot, where peer specialists have been able to connect with someone that other staff were having difficulty connecting with. And then once that connection was made, the peer specialist and the clinical staff can sit down together and help each other understand sort of what's going on with the other person, and help the staff then see how they may better connect.
Can you give an example of that, please?
Pardon?
Can he give an example of that? I know what he's saying, but could he just give an example, like a scenario?
Yeah, I kind of describe it as, the peer specialist kind of works as a translator. Is they explain to the individual what the system is saying, what the agency is saying, and they explain to the agency what the individual is saying, because lots of times there's a disconnect. I was doing a training one time and asked the group, how many of you were told what to expect when you saw a psychiatrist? And nobody told folks. Most people think that, the psychiatrist is you go, you lay down on the couch, That is not what psychiatry is. We don't do a really good job of explaining to individuals what to expect from services. Even from our crisis center here, if I take somebody over to the crisis center, the first thing I tell them is that this is going to take about 4 hours before you even know what they're going to do. And the flip side being is explaining to the agency, it's hard for this person to focus on their recovery when they're too busy trying to figure out where they're going to eat or sleep tonight. And having those kinds of conversations where the peer specialist is really kind of that translator between those two entities. Was that helpful, Vivian?
Well, I'm working with like the MHA recovery team. So then I try to build like an application based on what they wanted. And then I was telling her, like, I don't think they're concerned whether they have insurance or not. If they're not brushing their teeth, if they're not taking care of, and then there's the underlying problems with diabetes or, high cholesterol or something, and those are important things, but to just take care of like the situation they're in right now. And also like the cultural competency part of it, that's another big factor.
Oh yeah, absolutely, absolutely. The peer can be very skilled at helping the agency understand approaching the person where they're at. Yes, teeth brushing is very important, but being somewhere I have running water, I have to be there first. And really helping people, where they're at, And again, a great role that the peer support specialist can provide is having that understanding, because, we talked about, the concerns about the trust thing is that, as a peer, I may not be comfortable telling the clinician, even that, I'm homeless right now. I may or may not feel comfortable telling him, but I might be able to talk to the peer specialist about it. And the peer specialist can help work with the treatment team, to work on that situation. And again, finding that translator position can be very, very helpful. And adding into Vivian, what you were saying about the cultural competency part is, again, making sure that the peer specialists on your team represent the culture of the people you serve. Whether it be Native American, whether it be male, female, whether it be, people who have primary substance abuse or people that have primary mental health, is that making sure that the peer specialists represent the folks that you serve. Again, for providing that translator service.
Okay, another benefit that a peer specialist brings to an agency is teaching coping skills. I mean, anybody can teach people coping skills, but if you've been living with a disability, that disability may affect your ability to concentrate, to become engaged. When my father had his stroke, there was a community care worker who came by to work with him, to teach him to tie his shoes, to put his clothes on, to brush his teeth. And she would get so frustrated with him and his inability to do what she thought he ought to be able to do. And I thought at that time, I wonder how different the work would be if all of the people who were working with people who on how to rehab people on the other side of a stroke had a stroke. If that was one requirement for the worker, because probably one of the things that we tend to do sometimes is say to a person, why you don't have a right to look at everything you have going for you. Why are you so down on yourself? If they are down on themselves, they are down on themselves. And I think a peer specialist understands what a peer is going through and is able to validate a feeling when sometimes a person who has not experienced that has more difficulty validating that kind of feeling, and knowing what kind of skills would be helpful in this situation. Peer specialists do a lot of teaching WRAP, Wellness Recovery Action Plan, but one of the requirements to teach a WRAP is that you've been through and have your own WRAP plan so that you know what's involved in creating a WRAP. Peer specialists can help both the peer and the staff understand the recovery process and relate it to what's going on in the treatment process. Those are two different kinds of processes: treatment and the treatment process and the recovery process. Peer specialists help both the peer and the staff understand each other so that they can understand the other's concerns and what might be helpful and not helpful. Jean mentioned translator. I think of 3 words: translator, connector, and bridge, as one of the major roles that peer specialists play in a system, in terms of helping being the translator, the connector, or the bridge from the peer to the clinical staff, and back and forth that way.
At any point, do they advocate, or are they just there in the support process?
Do what? I didn't quite understand that, Vivian.
What do they just, like you said, the major roles are just translator, connection, and bridge. I get that. But say like if somebody had some experience working with, if they needed to go to an agency, and can we go with them, or do we just support them halfway there? And if we do go with them, do we advocate for them, or do we just sit in a support position?
First, when you go with a peer on a meeting with another professional, there's some things you need to make sure the peer understands. You are there to support them, not speak for them. So, but advocacy means basically, first of all, advocacy means preparing them to self-advocate. And then, and if they're having difficulty, maybe you can do some advocating for them in the meeting. The danger is, in many situations, the person that you're meeting with will start talking to the peer specialist as if the peer is not in the room. That's the danger. And so you want to always make sure before you go into the meeting that let's be clear, this is your meeting with so-and-so. I'm here to support you. I'm here to remind you of some things you said you wanted to bring up. I'm here to do that kind of background work, but I'm not here to take over the conversation. I'm here to help you have that conversation. Now, because the peer specialist has been both, quote, client and staff, they are able to see things in an agency that oftentimes other people don't see. So the peer specialist can help a staff and an agency identify what it's doing well and needs to continue to do and to strengthen it, and to what it may be doing that's not helpful, that they may need to quit doing it or reduce it. That's a major role. Now, that is a difficult role because oftentimes the peer specialist is seen as the lowest ring on the totem pole, the lowest of the staff. That's just the way it is when a new staff comes in. And oftentimes, if a peer specialist starts saying to an agency, you know, I don't think it's helpful when we do this, then there's a lot of times people sort of say, who are you to tell us what to do? So that takes some learning how to get that across, but that's a major role that a peer specialist can play, because you can see what an agency might be doing that is not helpful, because when you were receiving services and that happened, it was not helpful. And probably the best way to enter those conversations was to say, when I was receiving services and someone did this, I found it not helpful for the following reasons. So to put yourself back and show that you have experienced what is going on and why that wasn't helpful. Now, so those are some things that a peer specialist brings to benefit, the way the agency can benefit. Any questions about that list? That you may not remember them all, but you do have it on the sheet, on the material that is being sent out. But when you think peer specialist, one of the things that is helpful to think is educator, translator, bridge, connector, that kind of role that they are able to play in the system. Now, so peer specialists are most effective when the agency and clinical staff, especially their supervisor, understand their role, when they're treated as equals by other staff and have a voice at the table, and when the agency understands what they need for their own recovery and are given time for their own self-care. Now, this does not mean peer specialists take every Friday off as a mental health day. We try to communicate to peer specialists in the training, if you are not ready to work full-time, don't go to work full-time. Don't go to work full-time and ask for every Friday off. Don't use your mental illness as an excuse for not doing what you have been hired to do. Put yourself into a position where you are saying, I will work this many hours, and this is what I will be willing to work. But also the agency needs to understand, as they understand with any person with a chronic illness, that there may be some times when the person needs to take care of themselves, and the agency is prepared to let the peer do this. Now, often when a peer specialist is effectively used in an agency, motivation and engagement in treatment increases and recidivism decreases when the peer specialists are strategically placed. So that's just been one of the things that research has shown, that when you are able to use your peer specialists effectively, peers or clients tend to become more engaged in treatment and spend less time in intensive care or hospitalization. Now, second, the agency must work to incorporate the peer specialists into the agency and onto the treatment team. So it's not just the supervisor's work. There's some work the agency needs to be doing here. Peer specialists just are a new discipline that bring a different perspective and a different way of doing things. This new perspective is viewing situations from the perspective of having been there and done that, having figured out a way to successfully move on with their lives on the other side of a psychiatric diagnosis, and knowing the importance of personal relationships based on mutuality, authenticity, and choice. Now, another way of saying this is that peer specialists hold the perspective of the peer as much as possible. Now, the clinicians, we're going to get into this a little bit more, a little bit later, the difference in the peer perspective and the clinical perspective. The clinician is always asking, what, from my perspective and my education and my experience, what do I think is best for the client at this time? What have I learned that the client needs to move on with their life at this time? The peer specialist has a little bit different perspective. He's saying, what does the client want? How can I help my peer get this? And how can I help this move them forward in their own recovery? So there's two different, the peer is always trying to come at things from the perspective, the peer specialist is always trying to come at things from the perspective of the peer. Now, it's very difficult to understand what peer specialists do without having some understanding of recovery. Now, the definition of recovery that we use in the training, recovery is the process of gaining control of one's life and the direction one wants that life to go on the other side of a behavioral health diagnosis and all of the losses usually associated with that diagnosis. In the beginning of the trainings, we often ask the participants in the training program, what are 3 or 4 things that you have lost because of your mental illness and or addiction? And once they write down 3 to 5 things that they've lost, we come back and sort of say, how often has the system focused on helping you regain these losses? And most people will say that has not been the focus of the treatment. The focus of the treatment has more and often been dealing with the illness. Where we teach the training is focused on teaching the peer specialists not to deal with reducing the symptoms and reducing the disruptive behavior. That's the clinician's work. Don't worry about that. That's the clinicians are trained to do that. Your work as a peer specialist, we tell them, is to helping reduce the impact that the illness is having on your life. Now, the mental health system or the behavioral health system is in the process of making a shift. Now, that shift is from primarily focusing on stabilization and maintenance, disease and disability, what's wrong, staff-driven, staff-client hierarchy, behavioral health, social separation, compliance to a plan, and dependence. Now, that focus saves people's lives. I would imagine most peer specialists would be able to say at some point in their own journey that finding people that were focused on that saved their life. There was a time when the disease and the disability had taken over their life. They were not stable. They were not able to determine what was best for them. They needed someone to step in, like staff. They needed a plan. They did not have a plan. They were dependent on other people to help get them stable. The difficulty is when that's the only focus. So the shift recently in the behavioral health system has been to also focusing on recovery and resiliency, wellness and strengths, what's strong, client-driven or peer-driven, client-staff partnership, whole health, social integration, engagement in a process, and interdependence. Now, it's very interesting that the shift to recovery in the behavioral health system and bringing peer specialists on board as staff both happened about the same time, about 20 years ago. Is when the system really began to say, we need to start making this, looking more at recovery. So I often say the neighborhood was changing and there was a new kid on the block. That was what was going on. And so peer specialists have been able to play a major role in helping agencies make this shift from not just primarily focusing on the left side, but also beginning to focus more on bringing that into focus. Now, if effectively incorporated into an agency, this new perspective can help an agency enhance its focus at person-centered, recovery-focused services. Now, peer specialists offer an agency and a supervisor an opportunity to understand what is going on with a particular individual. A constant question that should be part of the team meetings goes something like this. Someone on the team saying, from your perspective, talking to the peer specialist, what do you see going on with so-and-so? The peer specialists do not do well in agencies that aren't focused on recovery. Now, there are two questions I think it's helpful for agencies to ask that sort of help them to see whether or not they are focused on recovery. The first question is, does the treatment planning process focus only on treating the illness or addiction? Or are there also significant person-centered recovery-focused goal statements included in the goal? Are that not, the illness has to be treated, but also is the treatment plan focused on helping a person get a life back? The second question is the client excited and committed to the goals in their treatment plan? When I work with staff, I have often had staff members to say, I can't get my clients to work on their goals. Well, usually the goals that you can't get them to work on are probably not their goals. They're the goals that someone else has created for them. And one of the roles of the peer specialist is to help that treatment plan really focus on what the peer wants. Now, let's move a little bit into how peer specialists differ from clinicians. The behavioral health system has traditionally expected its clinical staff to focus on treatment plans of reducing symptoms and disruptive behavior. It's usually the symptoms and the disruptive behavior that get people into treatment. And the clinicians are trained to deal with that. Most people diagnosed want more than just symptom reduction. They want a life. They agree that the greatest impact of a mental illness or addiction is often the sense of loss and disconnection. There's nothing a person can lose that can't be lost within the onset of a mental illness or addiction. Treatment plans seldom focus on this sense of loss and disconnection. Peer specialists are trained to focus on the impact of the illness has on a person's life. The peer specialist training curriculum focuses on reducing the impact of the illness rather than reducing the symptoms and disruptive behavior. Now, one of the things that's the focus of the training is built around the statement that what a person believes about themselves, because they have a diagnosis of mental illness, is often more disabling than the illness itself. If you talk with a person who has been able to get on the right medication, and therefore they're not experiencing the symptoms, and they're not manifesting the disruptive behavior, they will often still believe they can't hold a job, they can't do this, they can't do that. So it's not necessarily the symptoms that was keeping them from believing they could do something. It's their belief system. So the training that most of the peers go through when they go through the Appalachian Consulting training focuses on how do you help people change their beliefs about themselves. And we spend a lot of time in the training helping people get inside of those belief systems. What does the peer believe about him or herself that right now is working against them doing what the clinicians want them to do? Now, the relationship between a peer specialist differs from the relationship between a peer specialist and a peer, differs from the relationship of a clinician and a client. They're less hierarchical. They're more like a partnership. They revolve in more reciprocity, more give and take than usually the clinical relationships do. And they have less social distancing. It's a little bit more like a friendship. Therefore, the boundary issues are what is appropriate for a peer specialist and will differ from what is appropriate for other members of the treatment team. When we first started this program 20 years ago in Georgia, and we trained our first batch of peer specialists to go back and work in their agencies that had hired them, we had agency administrators oftentimes calling us and saying, peer specialists are talking about their personal life. They're not supposed to talk about their personal life. And we had to sort of come back and say, no, they're not talking about their personal life. They're talking about their recovery journey, their lived experience of recovery. But then we had to work with peer specialists on, there's a difference in talking about your lived experience with recovery and your personal life. You don't necessarily talk about your personal life with your peers, but you do talk about your lived experience in recovery. Now, William White, who many people see as the guru on the addiction side of peer support services, defines clinical services as traditional clinical services at their core, at their best, provide screening, assessment, diagnosis, treatment planning, and treatment delivery process, with a major focus on the quality of the helping relationship. He goes on to state peer support focuses on removing personal and environmental obstacles to recovery, recovery education, recovery check-in, and guidance to improve the quality of long-term recovery. So everything the peer specialist does or should be doing should focus on the recovery of their peers. Now, Clinicians are trained to diagnose and treat the illness. Their focus question is often, what does my training and experience tell me this client needs in relationship to their diagnosis and how I can get them to comply? One of the things we share in the training is that the peer specialist may be the only person on the treatment team who can work with an individual over a period of time and never need to know their diagnosis. A peer specialist can work with a person effectively over a period of time and never need to know their diagnosis. Let the clinicians worry about the diagnosis. One of the images that we do in the training, we talk about the impact of the illness on a person's life. And we use a quote from Patricia Deegan. She says, "The illness shattered her world, hopes, and dreams." And we have a picture of a beautiful vase being shattered by a hammer. Now, we train the peer specialists to let the clinicians decide what the hammer is. Is the hammer schizophrenia? Is the hammer bipolar? Is the hammer addiction? Is the hammer depression? Let the clinicians decide what shattered that life. It's the peer specialist's role to help them put the life back together again. Now, there are times with agencies, especially in the way they do their documentation, that they require our peer specialists to know something about the diagnosis of the client, the peer they're working with, in order to do the documentation. But you really don't need to. The peer specialist is not trained to diagnose, and the peer specialist is trained to help people put their life back together again. Any questions about that? That, as we've talked about the difference in the clinical approach and the peer specialist approach.
This is Twyla. I'd like to share something.
Yeah.
I'm a nurse by profession, and I agree to a certain extent that peer supports focus on just the one thing and clinicians focus on, the diagnosis and that sort of thing. But from a nursing perspective, I went from hospital care to long-term care, and there's a difference in philosophies, it felt like, from the CNAs. CNAs in the hospital were generally more in tune to diagnoses because it does affect how you care for them.
Right.
Where in long-term care, it's like everyone's created the same. No, they're not. You transfer somebody differently because you need to know that they have a fractured hip. You need to know that they had a stroke on this side. You need to know that they can't swallow. So I think sometimes it is important to know just a little bit about their clinical diagnosis, so you know why they're responding the way they are, why they're behaving the way they are. If they're diabetic, if they have a reaction, that sort of thing. It doesn't have to be the focus, but I think it's important sometimes to know that information. So I just wanted to share that.
Yeah, and I think it's important, especially if there are physical illnesses affecting a person's behavior or ability to function, that the peer specialist needs to know is the diabetes, the hip replacement, the other things. That's very important. But I just think it's very, we've been in this for 20 years with about 40 states we've working with. Probably one of the greatest temptations on the part of the clinician is to try to get the peer specialist to use their good relationship with the peer to get them to comply with treatment. That is not the role of a peer specialist, to get a person to comply with the treatment that a treatment team has come up with. Now, the peer specialist may have the conversation with the peer. Where are you having difficulty with this? What is going on? And listen to the peer's perspective, and then try to get the team to understand the peer's perspective and what may be going on with the client, quote, but it's not, they are not compliance policed, especially if they're on an ACT team. They so often get, would you go out and get so-and-so to get back on their meds? That is not a peer specialist role to get someone back on their meds. Peer specialist role may be to have a conversation with someone about the difficulties that they're having with their medication and to bring these difficulties to the team, but it's not to get them back on the meds. But I do agree with you, Twyla, that there are some things the peer needs to know, and especially if it's the long-term situation and they're working with people over a long period of time, and there are things that are affecting a person. There are things about the illness or the physical illness that is affecting a person's ability to function. I agree with you, and thank you for bringing that up.
Yeah, the example I often give is, especially on the mental health side, is that most people will have a half a dozen diagnoses in their lifetime. Is that really the important part is how is it interfering with the life that you want? Because you can have similar symptoms, whether it's an addiction, whether it's a mental illness, whether it's, whatever. The issue is that how is it interfering with your life?
One of the things that we've been doing this business for 20 years with peer specialists, and still, if you go out and ask a number of clinicians, what issues or concerns do you have about peer specialists? Probably the most common answer is, I don't understand why we hire them. I don't understand what they're supposed to be doing that we can't do. And so we're trying to spend a lot of time on this, getting you inside of the role of a peer specialist. Because if you're a supervisor of a peer specialist and you're a therapist, and your role is to make that peer specialist the best peer specialist possible, it's helpful to understand what we have learned that they do effectively and why an agency should hire them. If you ask a peer specialist, what are your concerns or issues that you face? Probably the number one thing that comes from the peer specialist is, I feel like a junior member on the team. I don't feel like I'm completely accepted as a full member of the team. It's been hard to bring the peer specialist into the system. I think two things are involved, at least, and these are two stigmas. One is the stigma of mental illness. There's probably no illness that changes the way we see a person's abilities more negatively than a mental illness. If you meet someone, and no matter how accepting you are, and in the meeting and then that conversation, you learn they have a diagnosis of mental illness, your relationship and the way you see them changes because of the strong stigma of mental illness and what we think people with a mental illness can and can't do. So you've got that stigma. And so you're bringing people into the system that the system was at one time set up to treat. And that's why it was such an unbelievable accomplishment to get Medicaid to say we will reimburse agencies for peer specialist work, because you've gotten the largest insurance company in the world to say those people that we were set up to provide services to and benefits to, we're now saying have something to offer that we're willing to pay an agency if you can get them to offer it. So that's a stigma that they bring. The other stigma is the stigma of education. Anybody before peer specialist, anybody who was providing a service, now I'm not talking about secretaries, janitor, receptionists, I'm talking about anybody who was providing a behavioral health service, probably had at least a college degree, and most had more than a college degree. And therefore, you bring someone on who has at least a high school education, and many not more than a high school education. We have peer specialists with master's degrees, doctor's degrees, all of it, but the minimal requirement is a high school degree. You bring people on, and it's very difficult for people who have sort of seen their profession as based on their educational degrees and requirements to bring this person onto the team. So now we want to talk about the third question. The third thing, the supervisor needs to work to make the peer. We've talked about what the agency needs to do to understand peer support, talking about what the agency needs to do to incorporate peer specialists in. We're talking specifically now about the supervisor. We sort of set the stage for this. What you do in supervision depends on your goals. I'm going to go over some stuff that will probably be very familiar to the supervisors to set the stage for this. If the goal, there are 3 accepted goals in supervision: educational, administrative, and supportive. If the goal is educational, the supervisor uses demonstration, modeling, discussion, feedback, and practice to support the learning of new skills. This is very difficult for a non-peer clinical supervisor to model and teach peer specialist support skills. So we're not quite as concerned about the educational role of a supervisor in the peer specialist relationship. Now, if the goal is administrative, the supervisor has time, task, attendance, oversight, ensures that the supervisee is in following the policies, rules, and procedures. Hopefully, this should be a minor focus. Are you showing up on time? Do you understand the policies of the agencies? Are you following the policies of the agency? Are you attending everything you need to attend? Hopefully that will be a minor issue unless it becomes a major issue. Now remember, oftentimes peer specialists, for many peer specialists, this is the first time they've worked in an agency like this. And so it may take some time to educate them about the policies of the agency, both the spoken and non-spoken, the written and the non-written policies. If the goal is supportive, the supervisor works to improve supervisee performance, but difficult to do when the supervisor relationship is non-peer-to-peer. Now, since this is not possible for peer specialists to supervise other peer specialists in most situations, how can a clinical supervisor make the supervisor-supervisee relationship as peer-to-peer as possible? How do you effectively supervise someone from a different discipline? Now, We talked earlier about the supervisor has to understand the philosophy and values of peer support and supervise from that perspective. What does this involve? First, it involves admitting they do not have all the answers and being open to learning. I know something, you maybe in your sort of early on in your meeting with your peer specialist supervisee, you might, a peer specialist supervisor might say something like this. I know something about supervision. I don't know much about being a peer support specialist. I assume you know that. We can both share and we can both learn. Let me start by sharing with you what I see as my role as a supervisor. And then share with the peer what you see as your role as a supervisor and what you've learned about supervision. Now, can you share with me what you see as your role as a peer support specialist? So being open to learning from the peer support specialist, what they see as their role. I've been in trainings where I've had a peer specialist say, you know, when I first met with my supervisor, the supervisor said, I don't know what you're supposed to be doing in this agency. You go out and figure what you do well and do it, and then come back and we will talk about it. And so that sort of left a lot of creativity and openness on the part of the peer specialist. And some peer specialists wanted more direction than that, but they had to figure out what they do well. And then they come back and base supervision on what they bring back to their supervisor. Research peer support and peer support services. You can do that in having conversations with people. You can do that by looking up on the internet and Googling it. There's a lot of stuff on the internet these days about peer support and peer support services. Have conversations with peer specialists about their lived experience. And we're going to share with you some tools later in the toolbox, some questions that you can ask that begin to help you get inside of another person's lived experience and how that can be helpful in working with people. Having conversations with peer specialists about their gifts, abilities, and their role. Again, there will be things in the toolbox that will help you when you go back. Go back to the other one, Jean. Having conversations, engaging in discussions on how the role of the peer specialist differs from the role of the typical clinician. That's a question asking you, how have clinicians helped you in your recovery? And I would dare say, I have not met peer specialists who would not be able to answer that question of how clinicians have helped them in their recovery. But having a conversation with your peer specialist about how have peer specialists helped you in your recovery when you were, before you became a peer specialist. That's one way of getting at the difference between the two. Now, the peer specialist needs to be an advocate. I mean, the supervisor needs to be an advocate for the peer support specialist. Therefore, early on in your relationship with the peer specialist, the supervisor should ask a question: do you feel that where you work and what you are doing is the best use of your gifts and abilities? If not, you need one of the roles of the supervisor is to advocate with the agency. I do not think we're using this peer specialist to the best of their abilities. Is there a way we could change their job description a little bit so that we could use them more effectively. Now, I want in your initial meeting, you may have already had your initial meeting if you're already supervising a peer specialist, but for those of you in agencies who are considering hiring peer specialists, in your initial meeting, review the job description and ask the peer specialist, do you think this reflects the unique role of a peer specialist? Is what the agency has you doing, does this reflect the unique role of a peer specialist? This is your first meeting. Establish a working partnership by both figuring out the rules of the relationship. When you're going to meet, how long you're going to meet, what you will talk about, how you will deal with administrative issues, time, attendance, following policies, and so forth, and how emergencies will be handled. And then discuss some expectations, short-term and long-term. Now, and that's that. Once you have that first meeting, then the ongoing meetings may follow some pattern like this. Summary of the last meeting by either of you. Switch slides, Gene. Summary of the last meeting by either of you. Progress on your goals, both the short-term goals and the long-term goals that were set up. Exploration of job stress. We're going to give you a conversation you can have with a peer specialist about job stress in the toolbox a little bit later. Opportunities to reframe what's going on, and then some mutual feedback. And then how do you add, subtract, or modify the goals that you're going to be working on to improve this person's effectiveness as a peer specialist? Now, any questions about those meetings? Any questions about what we've covered so far? For those, I'm going to speak now just a minute to those agencies that have not, the 45% of the agencies that have not hired peer specialists yet. You'll have in your manual, your handout, something called the foundation for the relationship is set in the hiring process. Okay, a little bit of a context. After setting up the peer support specialist training program in Georgia, helping peer support services set up in 25 plus states, and writing a resource kit for SAMHSA, Appalachian Consulting Group has identified some issues that an agency or a mental health system needs to think through before hiring peer specialists. The most important question is, where and how will people in recovery be used in the behavioral health system? It is very important to create a job description for people in recovery who are working in the peer specialist providers that ensure they can work from the peer recovery lived experience perspective. When writing this job description, it would be helpful to keep the following in mind. What are they expected to do on a daily basis that allows them to use what they have learned from recovery, about recovery, from their lived experience and certification training? 2, their work responsibilities are based on a set of competencies or teachable skills and knowledges that has helped them use their lived experience. Call forth the strengths of the individual that they have. So look at your training program that all of the people will have gone through. Figure out what skills they have learned in their training, and where can these skills be best used within your agency, and how do you include using these skills as part of their work responsibilities. Do not put them in positions where they cannot have used those skills in their work. Now, their roles and expectations are held in a clearly defined job descriptions that honors their lived experience. If at all possible, if your agency is considering hiring peer specialists, bring in a few good peer specialists from another agency and get them to help you write the job description for your agency if you're just starting this out. For the supervision of peer specialists to be effective, there are a couple of questions that need to be answered. Does administration and management understand the gifts and abilities of the peer specialist? Now, this could also apply to the agencies that are already hiring and using peer specialists, the 55% of those of you here. Do you think administration and management understand the gifts and abilities of peer support specialists? We are going to give you in the toolkit some scales, some tools you can use to evaluate how well your agency understands the role of a peer specialist. Where can they best serve in the agency, and what it expects from them as the peer support specialist. We're also going to give you some tools that you can use in your agency to find out whether peer specialists that you've already hired feel that they are being used to the best of their ability. And we're going to give you some tools that you can use to sort of figure out how recovery oriented your agency is and where it may need to work more. Now, in your packet that you'll be looking at later, there is a scale on 1 to 5 as to how well you think your administration understands. But you'll get to that later. Now, we'll go over some of the, you may not be able to see these in your materials box, but I want to go over some of the tools that we're sending you giving you to use when you go back to your agency. The first one is peer specialist lived experience and training. We give you some questions that a supervisor may ask to help him or her understand the difference in clinical education and lived experience. Any one of the questions you can use to initiate a good 10-minute conversation. There are, I think, 8 questions on that page. We won't go over those. You can read them later. Any one of those questions could get you into a good 10 or 15-minute conversation to get inside of what the peers' lived experience has been like and how they think that lived experience can be helpful to them. The second tool we're going to give you is roles and expectations are clarified early in the relationship. This is another set of questions that you could ask. There needs to be an early conversation between the supervisor and the peer specialist regarding expectations, which might include, we're not saying it has to, but might include at the peer specialist's discretion what peer specialists want if mental health issues arrive at work. Now, Beyond what they can expect in a typical supervisor relationship, the following questions might be helpful in establishing a good relationship. Now, again, there are maybe 10 questions on that page. We won't go over all of them. I do want to go over some of them to let you sort of know what's in there. But do you understand the difference in supervision and therapy? That's an important question to get on the table. Well, Jean's putting all of these up. When a peer specialist, when a peer becomes a peer specialist and has a clinician as a supervisor, it is probably the first time a peer specialist has had a clinician in a relationship that it was not some kind of therapeutic relationship. Every relationship with the clinician prior to the relationship with the supervisor has probably been some kind of therapeutic relationship. And therefore, it's very easy for the supervisor's relationship with the peer specialist to begin to move into therapy. And you need to watch that. We've had it in conversations with peer specialists and supervisors. We've had it come up from both sides. We've had supervisors to say, my major problem is my peer specialist wants me to be their therapist, and I'm not going to be their therapist. And then we've had it come up from the peer specialist to say, the major problem is my supervisor wants to be my therapist, and I don't want them to be my therapist. I have a therapist. You need to watch that and begin to clarify what you will deal with in the supervisor relationship and what the peer specialist needs to take to their therapist. Now, there's a conversation you need to have with the peer specialist, but you need to have this conversation with everybody you supervise. It starts down at about a little more than halfway down. If you felt the stress of your job was becoming overwhelming, what would you do to take care of yourself? That's a better way to ask the question than if your mental illness issue starts coming up. What are you going to do to take care of yourself? Because that's a question you can ask anybody you supervise. Everybody gets impacted by stress. And so how are you going to deal with the stress of the work when it comes up? What might be some signs that I, as your supervisor, could look for that would let me know you're getting stressed out? Not that your mental health issues are coming up, you're getting stressed out. What might you want from me as your supervisor if the work stress is getting too much? And what might you want from the agency if the work stress is getting too much? That's the conversation you need to have with anybody. There are people with diabetes, stress affects their diabetes. There are people with heart conditions. There are people with all kinds of conditions that stress affects. And you want to make sure that you understand what they're doing to take care of themselves and how you or the agency may be helpful in that situation. Okay, another tool we're giving you. How recovery focused is your agency? Now, this tool has, I think it's 4 parts. There are 12 questions. We won't go over all 12 questions. Each of the 12 questions are the same on each part. One part is filled out, one page is filled out by the client, answering the same 12 questions. That one form is filled out by a management, one form is filled out by clinical staff, and one form is filled out by a peer specialist. They all fill out the similar form. I'll give you an example of how the questions may differ. Circle the appropriate number rating for your agreement with each of the following statements. This is any peer or client in your agency fills out this form. Staff help me understand my strengths and how to use them to accomplish my goals. Where administration would be answering, our agency helps clients understand their strengths and how to use them to accomplish their goals. The clinical staff would say, I help clients understand their strengths and how to use them to accomplish their goals. The peer specialist would say, the peers I work with understand their strengths and how to use them to accomplish their goals. The same 12 questions, but worded a little bit different for each of the population of the agency. Taking all of that and beginning to say, where do we disagree? Where do we agree? Trying to get a feel for how we're on the same page or not on the same page when it comes to being recovery oriented. A great tool to use when you go back to your agency. Because remember, peer specialists do not do well in agencies that aren't focused on recovery. Now, the next tool is the role and responsibilities of the peer specialist. Again, there are, I think this one has 3 forms, all answering the similar questions. But it starts out with our agencies, one from management and administration, who are usually not necessarily providing direct services, one for the peer specialist supervisor, and one for the peer specialist. I'll give you an example. Our agency peer specialist job description, position in the agency, and employment responsibilities allows, supports, and encourages and provides them with regular opportunities. We're talking about the peer specialists, provide peer specialists with the regular opportunities to create and strengthen their trust relationships with their peers. From a management perspective, do you think where you have them working does this? Then the supervisor answers the same question, and the peer specialist answers a similar question. But that goes all the way through, helps them initiate and sustain peers in recovery, teaches wellness management skills, whole list of another 12 or so questions that you can use with your peer specialist to see whether or not you are using your peer specialist effectively. Any questions about those tools, how you may use them when you go back to your agency? Okay, let's just step back now. And there are some challenges and concerns that we want to just talk about in our last few minutes before we break this training. First is, what are some concerns or challenges that you're leaving with? We spent almost 3 hours talking through this topic. What are some concerns or challenges you're leaving with? Or to say that in another way, what have we not talked about or not talked about enough to need to clarify more clarity on? Now, one of the things that if this had been an all day, most of our supervisor trainings are a full day. And most of our supervisor trainings have role plays, scenarios where we break into small groups. We did not think that would be possible to do a lot of this, but where we go in and say, if you were in a supervisor situation, this was the situation, what would you do? But what are some of the concerns you're leaving with? We've shortened this, and I'm sure there's things we haven't talked about enough, or you wish we had talked about more.